patients sometimes come in and say, you know, doctor, I've tried everything and nothing has worked. And then the challenge is to figure out why it is that treatment hasn't worked. And there are a number of common reasons the treatment may fail. Perhaps the first and most important is that the diagnosis is either incorrect or incomplete. So many patients I see who've tried and failed multiple therapies may come in with a diagnosis of migraine, and they might have something else, hemicrania continua, giant cell arteritis, or whatever. And sometimes patients have more than one disorder, so you successfully treat one disorder, the patient is left with the second undiagnosed disorder. So the first step is always to make sure that you have a correct and complete diagnosis before proceeding. And then treatment may fail for a number of other reasons. Another common one is that the patient has triggers that are either unaddressed or unidentified. So triggers initiate or increase the probability of getting a headache after exposure. So far and away, the most common trigger that makes patients difficult to treat is overuse of the same medications they're taking to relieve their headache. So a patient who's taking an over-the-counter medication that contains caffeine on a daily basis may not get better because the very medicine they take to relieve their pain triggers the next headache as it wears off. As an example, I once saw a patient for a very long time. They weren't getting better on treatment, and every time I saw them, I was asking about whether they were overusing caffeine, and the patient would always say, well, I don't really drink coffee. It turned out the patient was drinking Lipton iced tea, my name, 8 glasses a day, and it was the caffeine that was perpetuating his headache. And it took me months before I realized he was drinking the iced tea, and when I eliminated it, he finally got better. So looking for trigger factors, and they could be life stresses, they could be disrupted sleep, they could be a stressful job, could be an overused medication, often helps convert failure into treatment success. And then another reason treatment may go wrong is that people choose preventive medications that are used inadequately. So very often when a patient says, I've tried and failed every known preventive drug, that may mean they've taken topiramate for 3 days, which isn't long enough for it to work, and given up on it. It may mean that they've taken an inadequate dose of a beta blocker and then given up. So it's often worth revisiting what medications they've tried and failed, making sure that the preventive medicines are the ones that are appropriate to the patient's complete diagnosis that's been reassessed. And also sometimes preventive treatment may fail, not because the preventive drug won't work for the patient, but because of the unaddressed trigger factor. The word prevention itself creates unrealistic expectations for patients, because you say to a patient, I'm going to give you a preventive medicine, and they may assume, well, as soon as I take the drug, I'll never have another headache. And the reality is that for oral preventives, benefits develop slowly. The definition of success is reducing headache frequency by 50%. So it's very important to shape patients' expectations, because sometimes patients start on a preventive treatment, and they might have been having 5 headache days a month. They go down to 2 headache days a month, and then, but when they get that headache, they discontinue therapy because they think my preventive failed. But unfortunately, success doesn't mean completely eliminating headache. It means reducing frequency and severity of headache. It's also important to recognize, particularly for migraine, that many patients have nausea or vomiting and may not absorb oral medications. So another common reason for acute treatment failure is the patient needs a non-oral therapy, a nasal spray, an injection, and is given an oral therapy that they're unable to absorb in the midst of a migraine attack. For primary failure, if medicine isn't working in the setting of prominent nausea or vomiting, it means you need to try non-oral therapy, because there's a very good chance that whatever oral treatment you try, the patient's not going to be able to absorb. So obviously everyone always says, well, drugs can't work if you don't take them, and that's true, but drugs don't work if you don't absorb them. So in the setting of gastric paresis or prominent nausea, you need to give drugs in a way that they can get in so that the patient will be able to respond to them. The reality is that migraine is a chronic disease, and like all chronic diseases, we can't cure migraine, but we can make it a lot easier to live with. And if the doctor and patient are aligned on what success looks like, it becomes much easier to achieve success and to make the patient satisfied with the treatment that's available.